Hi everyone, welcome back. As promised, I will be doing this video on oral anticoagulants, and then I will be doing the next one on parenteral anticoagulants. So the focus of these videos is not going to be on dosing. I think that is something that any one of us could easily look up. And these anticoagulants are approved for so many indications, for the treatment of venous thromboembolism, or for prevention of stroke and VTE with AFib, or for prevention of VTE in medical patients, orthopedic patients, and whatnot. So the dosing can always be looked up, but what is important in my perspective is to know when to use which one. There's so many anticoagulants, and our job really is to figure out what the best one is for particular patients and in particular situations. And so that will sort of be the goal of both these videos. I will be talking about what differentiates them, what's unique about them, and we will go from there. So let's start with an overview of these anticoagulants. So we have the oral ones, and then we have the parenteral ones that include IM, sub-Q, IV, all of those formulations. So under parenteral anticoagulants, our options include unfractionated heparin, low molecular weight heparin, enoxaparin or Lovenox is the one that's most commonly used, fondaparinux, argatroban, and bivalirudin. So I will be doing the next video on these agents and giving you a lot more information about those. But our focus for this video is going to be on oral anticoagulants that include dabigatran, apixaban, rivaroxaban, edoxaban, btrixaban, and Warfarin. The first drug class that I will be focusing on is the direct thrombin inhibitors. And argatroban, bivalirudin, and dabigatran all are part of this drug class. So the direct thrombin inhibitors, or DTIs, bind to thrombin and inhibit its action. Thrombin, or factor 2A, is the final enzyme of the clotting cascade that produces fibrin. So this is how they exert their anticoagulation effect. Now, as mentioned before, argatroban and bivalirudin are IV agents, so I will be talking about them in the next video. This one will focus on dabigatran. So dabigatran, brand name Pradaxa, is an oral anticoagulant. It is in fact a prodrug that is converted in the liver to its active form. It has fixed dose regimens based on indication. What do I mean by that? Well, and this is true for all DOACs, is as compared to Warfarin, where your dose changes day to day, week to week, or month to month based on the INR test. For all of the DOACs, that is not the case. Based on the indication, there is a specific dose that is indicated, and that dose could be different based on the renal function or some of these factors, but it's not based on any particular test like the INR that we do for Warfarin. And for the treatment of venous thromboembolism, a parenteral anticoagulation has to be given for at least 5 days and up to 10 days before starting dabigatran. So as far as I know, there's no specific reason for it except that this is how it was studied in the clinical trials. And in order to make sure that we have the same or similar outcomes, we have to follow the clinical trials. There is a theory that the first week or couple of weeks, the clot burden is really high. And usually you want to make sure that you maximize your anticoagulation treatment. So this is actually one of the reasons that Pradaxa or dabigatran is actually not used very often for the treatment of VTE. because the really big upside for the DOACs is that you can just start the patient on the DOAC and send them home. But for these parenteral anticoagulation for 10 days, you either have to keep them in the hospital or send them home with injections, and that just adds to the whole complicated regimen as it is. The maximum anticoagulation effect is achieved within 2 to 3 hours of ingestion, which is pretty good. And the downside, however, for dabigatran is that it is renally excreted and quite extensively, up to 80%. Therefore, it requires dosage adjustment in patients who have renal impairment, and it is actually contraindicated in patients who have creatinine clearance less than 15 milliliters per minute or patients who are on hemodialysis. It is also a substrate for P-glycoprotein and therefore should be avoided in strong PGP inducers, for example, rifampin, and strong PGP inhibitors, for example, ketoconazole and verapamil. Monitoring-wise, there's actually no routine monitoring, so nothing like an INR that we can do for warfarin. And based on how you're looking at it, that could be a good thing or a bad thing. The good thing, because obviously it takes away the inconvenience of doing the INR testing. Those are actual either blood draws or finger sticks or whatnot. They may be minor inconvenience, but they are still inconvenient to many. However, it also adds to the problem where if you have drug interactions, if you have a failure, you can't really do a test and say, well, patient was, sub-anticoagulated, and that's why this happened. So adherence is very important. And again, you won't be able to do a test to figure out if the patient is actually taking it. Not routinely, at least. There are other tests that you can do. So typically, you definitely want to get a complete blood count, CBC, and a BMP where you can assess the renal function. And typically, this is done at least yearly, more frequently if there's reasons to do so. And if you want to look at how exactly dabigatran is working and sort of looking in particular its anticoagulation effect, then we can do a couple of tests like eccrine clotting time or dilute thrombin time. However, those are not readily available in most labs, and they're not recommended by any of the guidelines. So efficacy-wise, dabigatran and all of the DOACs are at least as effective as warfarin, and in some situations slightly more effective. However, as bleeding-wise, all of the DOACs have a slightly better bleeding profile in terms of the risk of intracranial hemorrhage, which is one of the most severe ones we look at. So dabigatran, including all of the DOACs, does have a lower risk of intracranial hemorrhage and death as compared to warfarin. However, dabigatran does have a higher risk of GI bleeding as compared to warfarin. One of the most common side effects for dabigatran actually is dyspepsia, and some people say that taking with food helps. However, some people may not be able to tolerate it altogether. A really important thing to keep in mind is that dabigatran capsules should only be dispensed and stored in the original bottle. There is a potential for product breakdown from moisture, which can result in loss of potency, which results in loss of efficacy. So always make sure that you dispense these capsules in the original bottle, and the capsules also cannot be crushed or opened. They should not be crushed or opened. This can lead to a dramatic increase in oral bioavailability, and that can increase the bleeding risk. So next we will be talking about factor Xa inhibitors. These agents actually bind to factor Xa and prevent thrombin generation, which prevents escalation of the clotting cascade. That is how these agents exert their anticoagulation effect. And we actually do not currently have a parenteral factor Xa inhibitor in clinical use. So all the ones that we do have are oral agents: apixaban, rivaroxaban, edoxaban, and btrixaban. So I will talk about all of these agents specifically, but first off, I wanted to start off with important things to know regarding the factor Xa inhibitors as a class. So they all have the fixed dose that I talked about earlier, and that varies based on the indication. And the dose is also based on the renal function. So for a lot of indications, there will be dosage adjustments that will be required based on the patient's renal function. They do not, again, have any routine monitoring, except you should be getting a CBC to look at their hemoglobin and hematocrit and BNP for renal function, and LFTs at baseline, at least yearly, and more often if there's reason to believe that there might be something going on. And an important thing to know is that the anti-factor Xa, this is a level that we can get. Usually it is calibrated to either enoxaparin, a low molecular weight heparin, or unfractionated heparin. And those ones actually are not studied really well in, when you're looking at these factor 10, the oral factor Xa inhibitors. So a normal anti-10A calibrated to either unfractionated heparin or low molecular weight heparin may rule out significant drug levels. So if it's normal, you could safely say that the patient likely does not have significant drug levels of these factor Xa inhibitors. But if it's elevated, you really you don't have any way of quantifying it. So if it's high, it's just high. It could be high because there is significant concentrations of the drug left. It may not be. Whether that's clinically relevant or what is clinically relevant is actually unknown. You can have anti-factor Xa calibrated to each of these specific drugs. And I know some of the teaching, hospitals, large medical centers do that, but this is not something that is usually done. It is not readily available in any of the labs, nor it is recommended to get those because, again, those levels are not very well correlated with outcomes. For all of these factor Xa inhibitors, they should be avoided in severe hepatic impairment. There's a risk of accumulation, and the dose needs to be adjusted, as I mentioned before, in patients with renal dysfunction. They all are partially renally excreted to varying degrees, and so you always have to look at the package insert, at the dosing recommendations to see when you need to make an adjustment to a dose based on the patient's renal function. All right, so the first factor Xa inhibitor that we will focus on is rivaroxaban, brand name Xarelto. And the one unique thing about this medication is its dosing for venous thromboembolism. So if you are treating venous thromboembolism, you do have this loading dose period. So it needs to be dosed 15 milligrams BID for 21 days. And then the dose goes to 20 milligrams daily thereafter. Obviously, the dose may vary based on the renal function. This is for somebody with good renal function. The dosing needs to be this. This is very, very important. As I mentioned, this drug, along with other DOACs, can be used for various different indications. There's something like AFib, you would just start off with the 20 milligrams daily. So it's really important that you figure out what the indication is and make sure that for VTE, you do start with this loading dose period, which lasts for 21 days. Another extremely important thing to know about rivaroxaban is that 15 and 20 milligram tablets should be taken with food to maximize absorption. So what happens is if you don't take them with food, you may not absorb enough of it, and that could lead to a therapy failure because you just did not have enough drug in the system. So that is a very, very important point to consult your patients with. In our hospital, rivaroxaban is when you try to enter the order, it is defaulted to daily with dinner. Obviously, you can go in and change it, but the default setting is daily with dinner, so that helps to prevent a lot of the errors in case somebody forgets. And as mentioned before, all of the factor 10A inhibitors are renally excreted. So is this one. And it is actually contraindicated in patients who have creatinine clearance less than 15 or 30 milliliters per minute based on the specific indication. And it is also contraindicated in significant hepatic impairment, so in Child-Pugh class B and C. Now, it does have some significant drug interactions, much less than warfarin, but the few that do exist are significant and either lead to contraindication, that means you can't use it with those medications, or requires dosage adjustment. So whenever you see these agents concomitantly used, you have to make sure that you are looking at the contraindications and if there are any dosing adjustments. So potent dual inhibitors of CYP3A4 and PGP. So those are systemic ketoconazole, itraconazole, voriconazole, posaconazole, and ritonavir can significantly interact with the rivaroxaban, as well as potent inducers of CYP3A4. So those are the rifamycins, carbamazepine, St. John's wort. So in one case, you could lead to the risk of accumulation and bleeding. So that's with the inhibitors because you're not metabolizing rivaroxaban. And then in case of potent inducers, you are inducing pretty much the metabolism of this drug. So that could lead to therapy failure. You're not anticoagulated as you need to be. Alrighty, moving on to apixaban, or brand name Eliquis. This one also has a loading dose period, but it is far shorter than rivaroxaban. So for the treatment of venous thromboembolism, it is dosed 10 milligrams BID for 7 days, and then it goes down to 5 milligrams BID. And this is only for the treatment of VTE. Now, for the indication of AFib, atrial fibrillation, it is actually dosed in a very unique way. I don't know many drugs that are dosed this way. So you have the regular dose, which is 5 milligrams BID for AFib, unless your patient meets 2 of the following criteria. If their age is 80 or older, if their body weight is 60 kilograms or lower, or if their serum creatinine is 1.5 milligrams per deciliter or higher. So if your patient meets 2 of these criteria, that could be any 2 in whatever combination, then the dose is reduced to 2.5 milligrams BID, essentially half the dose. So this is very unique for this drug, and this is also very important to remember. Again, always look up the dose when you're treating your patient to make sure that you are giving them the right dose. For all of these DOACs, the dose is going to vary based on the indication, renal function, maybe some other factors. So, similar to rivaroxaban, apixaban also has interactions with CYP3A4 and PGP inhibitors and inducers. So dose reductions are recommended for patients who are receiving strong dual inhibitors of CYP3A4 and PGP. So that is something that you always should look up the interactions and see what the recommendation is. The package insert will list several of these. The great thing about apixaban is that it is one of the least renally cleared drug of all 10A inhibitors. So this works in its favor. That means that more people, even with renal dysfunction, can actually take this drug. There is very limited data available on safety and efficacy in patients who have creatinine clearance less than 50 milliliters per minute, but there are some post-marketing and observational studies that have shown that it actually is even safe in patients with hemodialysis in certain indications. This should also be avoided in significant hepatic impairment or Child-Pugh classes B and C. All right, so the next factor 10A inhibitor that I'm going to be talking about is actually one that I have rarely seen being used, at least in my neck of the woods. I think over the years there was one patient that I remember being on it, and he was traveling from another part of the country. So that's edoxaban, or brand name Savesa. And actually similar to the dabigatran, for the treatment of venous thromboembolism, it is required that a parenteral anticoagulant is given for 5 to 10 days before you start edoxaban. So just a point of clarification, this is not a bridge. So for warfarin, we do a bridge with a parenteral anticoagulation, usually enoxaparin. And that is when you're taking both drugs at the same time, because you're waiting for warfarin to reach its full anticoagulant effect. And once it does, once it reaches INR of 2, then you stop the other one and you just continue with warfarin. This is different for both Pradaxa or dabigatran and edoxaban. This is a 5-day lead-in period where you're only using the parenteral anticoagulant, and then after at the appropriate time, so if it's an enoxaparin, the 12 hours after based on the renal function, or when you shut off the IV unfractionated heparin, then you start either of these drugs. But they do require 5 to 10 days at least of a parenteral anticoagulant prior. Edoxaban is also renally excreted, so it is not recommended to be used in patients with creatinine clearance less than 15 milliliters per minute due to the risk of bleeding, because they can accumulate a lot of it. And interestingly enough, it is also not recommended to be used in patients with creatinine clearance greater than 95 milliliters per minute, particularly in AFib. And that is because the studies have actually shown that it has reduced efficacy, that in those patients, they actually clear it too well, and so they don't have sufficient anticoagulation coverage that they require. So that's really important to know both of the cutoffs and make sure that your patients that have either creatinine clearance greater than 95 or less than 15 are not getting it. This drug is also a substrate for PGP, P-glycoprotein, so it does interact with PGP inducers and inhibitors, so always keep that in mind when you're looking at the concomitant medications. Alrighty, next up is our latest factor 10A inhibitor. It's btrixaban, brand name Pradaxa, and it is actually only approved for prevention of VTE in hospitalized adult medical patients for up to 42 days. So that's a very unique indication. And important things to know about this drug is that it should be taken with food. And it is also renally excreted. So the dose is reduced for patients who have creatinine clearance less than 30 milliliters per minute. And it is also a substrate for P-glycoprotein, PGP. So the dose should be reduced if you have concomitant PGP inhibitors on board. As I've mentioned several times so far, all of the DOACs are renally excreted to some point and therefore require renal dose adjustments, or they're contraindicated at certain level of renal dysfunction. So here I wanted to give you an idea of how much of the drug is actually renally excreted, and we're talking about the actual active drug here. For most of these drugs, they are metabolized, by the liver. And once they're metabolized, most of the times they're not active metabolites. And so those are not as relevant in terms of increasing the risk of bleeding. But here we're talking about the actual active drug that could, if accumulated, could increase the risk of bleeding. So for dabigatran, it is actually 80% of it is renally excreted, as compared to edoxaban, which is 50%, rivaroxaban 36%, and apixaban 27%. So, as I mentioned before, apixaban is usually the drug of choice in patients who do have some degree of renal dysfunction. Rivaroxaban is also okay based on how bad the kidneys are working. And then you have to be extra cautious with dabigatran and edoxaban, particularly dabigatran. Besides the DOACs, we also have another oral anticoagulant, the good old vitamin K antagonist, Warfarin. So, Warfarin basically disrupts hepatic production of coagulation factors 2, 7, 9, and 10, as well as your body's natural anticoagulants that are proteins C and S. So the production of these factors and proteins requires the presence of vitamin K, and these clotting factors are biologically activated by the addition of carboxyl groups to key glutamic acid residues within the protein structure. So in the process, the active vitamin K is oxidatively converted to an inactive form, which is then subsequently reactivated by the vitamin K epoxide reductase complex 1, or VCORC1. And what Warfarin does is that it competitively inhibits the VCORC1 complex and thereby depletes the functional vitamin K reserves, and then therefore reduces the synthesis of active clotting factors. So that's a whole long way that it works, but essentially it depletes the clotting factors that require vitamin K for synthesis. So Warfarin, as we all know, it is available orally, and the dose actually depends on the INR, and it varies from day to day and month to month. Very, very, very rarely I meet a patient who's taking the same dose every day. Most patients take a combination of, for example, 5 milligrams Monday, Tuesday, or Monday, Wednesday, Friday, and then 2.5 milligrams the other 4 days, or, 4 milligrams Thursday, Friday, 2 milligrams other 5 days, something like that. And based on your INR, it can vary. So most of these patients initially actually are tested every 2 to 3 days. Once they're stable, then weekly, then they're stable, then every 2 weeks, and then eventually up to a month, sometimes 5 to 6 weeks. But that's the longest they go. They do have to test at least every 4 to 6 weeks, even if they've been stable, because, something could change. And to make things easier, actually, a lot of the companies have created tests that patients can perform at home. So those are simple finger sticks that the patients can do in their homes without trouble, or at least inconvenience of having to drive to a lab or a clinic, which has made life easier for a lot of the elderly, at least. But it is a hassle, and it is something that you have to do and change a dose based on that. So no fixed dosing that we have with the DOACs. Warfarin is metabolized by the liver, about 92% of it, and it's excreted via urine as metabolites. So you would say that it should be contraindicated in hepatic dysfunction, but it's not, because you can change the dose based on the INR. So if patients do have hepatic dysfunction where they're not able to metabolize warfarin as somebody with a normal liver would do, then you would see that in their rising INR, and you would just simply have to reduce the dose. This is actually, the INR testing could be considered a hassle and a disadvantage, but it's also, in a way, is an advantage, because you are able to get that INR and adjust the dose. So if there are any drug interactions, you can account for those. If there's any liver, renal dysfunction, you can also account for that. So in terms of laboratory testing, as we already talked about, is PT-INR, which every patient requires at different frequencies. A baseline and periodic CBC is also recommended, as well as baseline and periodic liver function tests. So that concludes my discussion on all of these specific oral anticoagulants, but I also wanted to shift gears a little bit and do a little bit of a comparison between these drugs, particularly Warfarin versus Doax, and sort of give you the advantages and limitations of each. That way, we can always more easily determine what should be used in what kinds of patients, and to make sure that we do prescribe them correctly, because Warfarin does have a place in therapy and it does have advantages, and so do the Doax. So in terms of advantages of Warfarin over Doax, it certainly has a longer duration of anticoagulant effect. So that allows for once daily dosing. Now, you may argue that some of the Doax do also have that, sort of rivaroxaban, certainly edoxaban, and that is very true. But we also have the btrixaban and apixaban, which are dosed twice daily. That could be considered a minor hassle. However, and it actually is, and there are studies to show that adherence goes down when the frequency of the drugs is increased. So compared to once daily versus twice daily, you're more likely to miss doses if you're taking something twice daily. And that makes sense. However, with Warfarin, it's once daily, and its duration is far longer. So sometimes even if you miss one dose, you're sometimes okay. You're still within the INR goal as long as you don't miss too many doses. Another advantage that I personally do consider an advantage, and I do see why it can also be a disadvantage. However, INR, so that is something that you can test if you have patients that are taking drugs or they're starting interacting drugs. You could always monitor their INR, and any sort of, what condition, you can monitor an INR and know exactly where your patient stands in terms of their anticoagulation status. And those INR tests are readily available everywhere. Any lab that you could think of will have an INR test available, as well as hundreds of Coumadin clinics that are open nationwide, where you're able to, if you sign up for those, you could get your INR done with a finger stick as opposed to an actual blood draw. It is also a safe option for patients with renal dysfunction or hepatic dysfunction. Actually, like I said, you can always monitor the INR, and it costs nothing, literally a few cents a tablet. So the extremely low cost is definitely a huge advantage of Warfarin over Doax. For the Doax, we often have to look at their, whether or not the insurance covers it, and which one is covered, or get prior auths and whatnot. So that's always a bit of an annoyance. Okay, now let's talk about some of the limitations of Warfarin. And one of the major ones is actually a delayed onset of action and the need to bridge with a parenteral anticoagulant. So that's something that I mentioned before. You can't just start somebody on Warfarin, especially when they are being treated for venous thromboembolism. Warfarin takes days to work. So you have to make sure that they are on a parenteral anticoagulant that works right away while their INR is increasing and finally reaches 2.0. Another downside could be its very long duration of action. So I know I mentioned that as an advantage, but it also can be a disadvantage because it must be discontinued 5 days before surgeries. So you have to make sure that any of your surgeries that you're planning, is planned accordingly, and that Warfarin is discontinued on time. And depending on your risk, you may have to take a parenteral anticoagulant in the meantime, And then same thing goes, after surgeries. And also, if you were to bleed, because warfarin remains in your system for so long, we may have to reverse it, as opposed to knowing, that the DOACs really only stay with your system for a short amount of time. And, unless it's life-threatening bleeding, we can usually just wait it out. Another disadvantage of warfarin is actually skin necrosis or gangrenes that it can cause due to paradoxical local thrombosis. So remember, it not only inhibits production of some of the clotting factors, but also protein C and S, which are your body's natural anticoagulants. So the risk of the skin necrosis and gangrene actually is increased in patients who do have this protein C or S deficiency. It's a rare occurrence. I haven't seen that in very many patients, but it is still a limitation. A big limitation of warfarin, and that does not apply to DOACs, is that its dose is affected by diet, and big time. So particularly your vitamin K intake can change your INR very, very, very quickly. So most patients will be advised to eat a very well-balanced diet, and that if they do eat a certain amount of vitamin K, that they should be eating it every day, as opposed to, one day you binge on spinach and then you never look at it again for a week. So this could be hard for some people. Maybe for some people, their diets or their meals are not prepared ahead of time or even thought of ahead of time. So it's difficult for them to really plan and take in the exact same amount of vitamin K day to day. Warfarin also has numerous drug-drug and drug-food interactions. The DOACs have some drug-drug interactions, but nearly nowhere close to what warfarin has. And again, the frequent INR monitoring and subsequent dose adjustments could be bothersome to some people. And most of my patients at least, never remember what dose they're taking. So they always have to make sure that they have it written down somewhere and fill their pill boxes accordingly. Another limitation is the hepatic impairment, and that does increase warfarin's sensitivity in certain patients. But again, this is something that is very easily manageable by just doing an INR test. There are variants in CYP2C9 and VCORC1 that can increase or decrease sensitivity to warfarin. And this is not something that we do routinely. We don't, if we're studying somebody on warfarin, we actually don't go ahead and do the genetic testing. But it is important to know how the variants in some of these genes can actually lead to a patient requiring higher or lower doses. And again, that's why you can never predict for anybody what the dose they're going to be on. You just have to start it and kind of monitor them very closely. All right, so that essentially wraps up my discussion on oral anticoagulants. If you have any questions, please feel free to leave comments and I will try my best to get back to you. I will be doing something similar on parenteral anticoagulants in the next video. So I will be focusing on the agents that I mentioned earlier and hopefully give you a little bit more information about those. Until then, take care.